Okay guys, so we are going to be doing something a little bit differently with this PowerPoint. In our liver patho PowerPoint, we talked about some liver conditions that would need further evaluation and further assessment. And these are pretty common exams or kind of add-ons to exams that you are going to be seeing out in clinical. So it's important that we start to talk about these now. A lot of these concepts are going to seem a little bit abstract until we get further into our physics course. And then we're also going to come back to these in our vascular course as well. So these are a little bit more in depth. These are a little bit, a step further into the complexity of some of the ultrasound exams that you will be performing. I don't expect you guys to be performing these images or these protocols, especially within this first semester, but over the summer semester and definitely into the fall semester, you will be expected to perform these protocols independently. But for now, I just want you to be aware of why some techs would be performing these images during certain abdominal exams while you are at clinical. So we're going to be talking about abdominal Dopplers, and I should be a little bit more specific with that. We're mainly just talking about Dopplers that are appropriate for the liver vessels. You can also do Dopplers of the renal arteries. We also do Dopplers of the ovaries and the testicles, depending on what we're looking for. So we're really kind of just talking today about performing Dopplers on the vessels that are associated with the liver and the liver function. So before we get started into any protocols or what pictures you would be taking for these types of exams, there are some things that we need to talk about really, really briefly. We are going to really dig into these topics in physics, so I don't want to spend too much time on them right now, but just to kind of give you an idea of what is going on as we move through the rest of the PowerPoint, we're going to be talking about some Doppler properties. Now, why do we do Doppler? Well, we know that we put color Doppler on something to see if there's blood flow, right? So we can put color on vessels, we can put color on organs, but how do we actually evaluate that vascularity? How can we get a numeric value to kind of help us figure out the function of that structure? We're going to be using our pulsed wave Doppler. So typically when we're in lab, we're putting color on something, and then sometimes I may say to you guys, let's Doppler that, right? And we put on our PW knobology, our pulsed wave Doppler, and that's when our screen kind of changes a little bit. And then we can really evaluate what we call the velocity of whatever kind of vessel we are sampling. So there's a lot that goes into that. There's a lot that's behind it, but that's kind of just the basic premise of using pulsed wave Doppler. We're using it to get an actual velocity of the region of the vessel that we're sampling so that we can measure it and we can say, hey, this falls within the normal velocity, or this velocity is looking a little bit abnormal. Now, it's important to remember that velocity is not the same as speed. So we are not measuring the speed of blood flow as it's traveling through a vessel. We are measuring the velocity. Now, speed is just the magnitude of something that is moving. Velocity is the magnitude and direction, both being taken into consideration for that. So velocity, yes, we are looking at the overall strength of that fluid as it's moving, and we're looking at the direction that it's moving in as well. Now, direction is very important when we are Dopplering vessels, and that's because we're looking for what is called the Doppler shift. And this is something that we are really going to get into in physics, but very basically you can have either a positive or a negative Doppler shift. And what this means is that when we are Dopplering an organ or we're Dopplering a vessel, nothing is moving, right, in terms of the transducer. We're keeping the transducer right where we need it to be, but we're picking up these positive or negative shifts in the frequency of the reflection being sent back to our transducer from inside the body. So what does this mean? This means that our transducer is sending in a sound wave. It's reaching this reflection, right? This reflector, which it could be the aorta, it could be the IVC, whatever vessel we're Dopplering, it reaches that. And because that structure is moving, it's a vessel. Remember, it's either going to pulsate or it's going to go with our breathing or it's going to be respiratory. But either way, our arteries and our veins are constantly moving. And that Doppler is picking up that shift in the movement from the vessel. Okay, so it's picking up the motion between the medium, so between the vessel and the transducer. And that's how we can see these reflections on our screen. That is a very basic way for us to put the Doppler shift of doing pulse wave Doppler. We will get more into that. So if it's not making too much sense to you right now, don't worry about it. Now, when I say that we can have positive and negative, this just means which direction is that reflector moving in. So is our vessel pulsating towards the transducer or is it pulsating away from the transducer? If it is moving, if that reflector with each pulse or with each breathing breath is moving closer towards the transducer, it's going to be a positive Doppler shift. If it's moving further away as it's pulsating or as it's being a respiratory phasicity, then it's going to be a negative Doppler shift. Positive Doppler shifts are typically going to be displayed above the baseline on our screen. Negative Doppler shifts are going to be displayed below the baseline on our screen. So we can kind of tell the direction depending on how this is appearing on our screen. Now, there are other things that we need to be aware of to make sure that that is accurate, but very basically, positive Doppler shifts, the reflector is moving closer to the sound source, the transducer, and it is appearing or being displayed above the baseline. Negative Doppler shifts, it is moving further away from the transducer while it's moving, and it's going to be displayed below the baseline. It's also important for us to know that we have to employ some type of angulation when we are doing pulse wave Doppler. This means that if, say, we're looking at our aorta on the screen, we're in a sagittal view of that aorta. Say our vessel is going directly parallel on the screen. That is going to create a perpendicular angle with our transducer. So let me just draw over here. Here's our screen, right? We know our transducer is coming down from the anterior portion of our view. But say our aorta is going directly across the screen like this. We don't have any angulation to it. Well, the sound wave is going to hit this reflector, hit that vessel, and bounce right back. Again, we're going to learn all about this in physics. And it's not going to pick up any Doppler. It's not going to pick up any color flow. And that's because there is no degree of incidence with this type of angulation or this lack of angulation. So when we are Dopplering something, we need either our vessel to be on an angle or our transducer to be on an angle. So if we are looking at our aorta and our transducer is coming down from the typical location, we want our aorta to look like this on the screen, or whatever vessel we're looking at to look like that, or it can go the other direction. So that when that sound wave comes in from the transducer, it's hitting it on an angle and it's not getting reflected directly back to the transducer. It's getting reflected off in an angle. Now, this is very abstract. Don't get too much into this, but you are going to see the techs do something called angle correct when they are Dopplering these vessels. And we'll look at that when we get into some pictures. But really quickly, let's talk about what spectral analysis is. Spectral analysis is, say you found a vessel, you put color on your vessel, and now you want to sample the velocity. You want to measure the velocity, so you're putting your pulsed wave Doppler on. When you hit that control, you are going to get a little portion of the screen that pops up underneath our image. It's going to be moving kind of like an EKG or an ECG machine, right? It's moving over time. So that is what we call our spectral analysis. That is where we are looking at the waveform and we are going to analyze that pattern. We're going to analyze how that waveform is appearing as we are Dopplering. The waveform itself, as it shows up, is in our spectral window. Okay, so we're looking at the waveform in the spectral window that is showing up on our spectral analysis. When we are doing that, we also need to be aware, so we're looking at two different things, right? When we have our pulse wave Doppler going, we have our waveform coming in at the bottom. We need to be aware not only of what our waveform looks like and what our spectral analysis is set at, but we also need to be looking at our screen. We need to be looking at our color Doppler evaluation. We also need to be looking at what is called our gate. So our gate, when we put on our pulse wave Doppler control, it's basically like the little cursor to a mouse on your computer, right? You put it where you want it to take a sample from. So we are placing that gate directly in the middle of a vessel, so we're getting accurate velocities, and we are putting it in the location of the vessel that we want to sample. So proximal, mid, distal, where do we want to pick up that velocity from so we can measure it? So it's basically just our cursor. Now with the gate, we can angle that to make sure that we are parallel, our gate is parallel in our vessel, but to also make sure that we have some type of angulation between our vessel and our transducer. So our gate is going to sit, I do have our pictures will show it on the next few slides, but our gate, so when we select that we are using our pulse wave Doppler, our gate's going to pop up and it's going to look something like this. This region is where we want to put it precisely where we want to sample from. So that's our little cursor, those two little parallel lines. Now we can turn this gate using angle correct so we can match the angulation of our vessel. So when we put our pulse wave Doppler on, and say we're using this picture on the bottom here, and our gate comes on, and say our angle is looking something like this. That's just how the control came on when we hit pulse wave Doppler. We would want to turn that so that it looks like this and fits in our vessel. Or we can heel toe our vessel to match the angulation of our gate. Either way, our gate should match the angulation of the vessel being sampled on the screen. That's how we are going to get accurate velocities. Again, we are going to learn all about this in our physics class, but for now, you just have to know these very basic broad topics. Now, when we're looking at our spectral analysis and we're getting our waveform of the vessel, we have our gate placed where we want it. We have the correct angulation of the gate. We have a proper angulation of our vessel in relationship to our transducer. Now we're looking at our waveform and we are analyzing that spectral waveform, that spectral Doppler. There's something that we really need to be aware of, and the first thing that we need to be adjusting is our scale. So how big of a window are we looking at, or how small of a window are we looking at? That is all going to be determined by the velocity of our waveform. The very top of our scale being displayed is called our Nyquist limit. This basically says, hey, with the scale that you have me set at, my Nyquist limit, the maximum value that I can show is going to be whatever you set my scale at. If the waveform of the vessel is coming in higher than whatever velocity you set for your scale, it's going to occur in what we call aliasing. Aliasing is going to occur, and that just means that the true velocity of the vessel that we are sampling is greater than the Nyquist limit that we have set for our scale. And it's going to make it look like it's wrapping around our spectral window. We do have an example of that in 2 slides, and we will get there, but it's important for us to know that scale is one of the first things we have to adjust when we are looking at our spectral window and we are analyzing that waveform. Another thing that we have to look at is our baseline. So we are going to see on both of our examples that you can adjust your baseline, and that is going to place your waveform in a particular region in that spectral window. We also want to be aware of our gain. Now, if our Doppler gain is set too high, just like our regular gain, it's going to make everything appear too bright. It's going to make the waveform look like it's way too strong, and that's going to be consistent with some pathologies. So we don't want to make our waveform look like it's turbulent or look like what there's called look like something that's called spectral broadening, where we don't have a nice, clean, clear waveform. So these are all things that we need to be aware of, and again, we are going to come back to these in a few weeks in our physics course. So here we have a beautiful, beautiful Doppler example. Look at our image first. We have a carotid artery being sampled. We see that that vessel is traveling in an angle across the screen, right? It's not traveling perfectly straight across. We see that our gate is matching that angulation. Let me change my color here because I'm using red on red. Our gate is matching that angulation of the vessel. So that's placed properly. And then we're getting this beautiful waveform in our spectral analysis. So all of this information that is coming up on the bottom of our screen, this is our spectral analysis. The space itself is our spectral window. Very confusing, but it is what it is. Now, when we are talking about our spectral window and we're talking about our scale, we're talking about the maximum velocity that we are saying to the machine that we want to display. So for example, on this spectral window, we have our gain set to about 120 centimeters per second for a velocity. Okay, so that is going to be our Nyquist limit for this type of setup of our image. Now you can increase your scale, and that would bring this scale up to 140, 160, 200, so on and so forth. Or you could decrease your scale so that your maximum value is 80 or 60, whatever you feel like is appropriate for that waveform. Now, we could bring this limit down to 100 so that the top of our window would be about here. And when you do that, when you decrease your scale and you kind of get rid of all of this excess space up here, it makes your waveform appear a little bit larger on the screen. It's not changing any of the values. It's not changing any of the properties of that waveform or of that vessel. It's just occupying more of that spectral window. So you get a little bit more of a clean and crisp image of that waveform. So we could probably decrease that Doppler scale to about 100, and we would still be showing the entire waveform. The peak velocity that it would come in at here would give us a calculation. Looks like it's coming in at 74 centimeters per second down there. Now you're probably thinking, well, it came in at 74 centimeters per second. Why couldn't we lower it to 80, our scale, right? It's kind of cutting it a little bit too close for us, right? So we want to have a little bit of room. We want to have a little bit of crust on the peanut butter and jelly sandwich, but we don't want too much where we're giving unnecessary information. Like all of this space up here is very unnecessary. We don't need that. So we could decrease our scale to an appropriate level. Now, if we set our scale, I'm going to erase what we have right here because there's a lot going on. Okay, if we set our scale at 40, right? We decrease, decrease, decrease. The top of our screen is 40. This whole waveform is going to be kind of zoomed in on, right? And we're going to be cutting off this whole region of that waveform. And what's going to happen to all of this information above that limit? It's going to pop up on the bottom of our screen and occur in what we call aliasing. So we'll see that on our next slide. But I think that was all the information I wanted to show. Oh, and then our baseline. So our baseline, that tends to be one of the first things that technologists will adjust. Physically, in terms of physical properties, the first thing you should be adjusting is your scale, but you are going to see a lot of techs adjusting their baseline first. So we said that all of this space up here is kind of excess, right? So you may see a tech move this baseline up so that now it looks like this. Now, it didn't make our waveform appear any larger. It didn't occupy any more space of the spectral window. We're not getting any more of a crisp appearance of our waveform. So yeah, it kind of gets rid of the extra space at the top of our spectral window, but it kind of just adds it down to the bottom underneath the baseline for that spectral window. So it is helpful to be adjusting our baseline. We do want our waveform to be nice and centered in the spectral window, but we want to make sure that we are completely getting rid of excess space in terms of our scale in order to get more accurate information and to get an overall better quality picture instead of just moving that space somewhere else. And that's what adjusting the baseline does. It takes the unnecessary space at the top and moves it to the bottom, or vice versa. All right, let's get into aliasing here. So if you see this while you are Dopplering, this is the classic appearance of aliasing. So basically what this means is that the peak velocity that this waveform is traveling at is higher than 20 centimeters per second. So really I kind of want to cross this off here because the peak velocity is really not 20.6 centimeters per second because they're measuring here as their peak velocity, but in reality, their peak velocity is here. So it's probably closer to 30 plus centimeters per second. So of course, 30 is greater than 20, right? Our Nyquist limit is set at 20 for our velocity. This waveform is coming in at a faster velocity than that. So it's going to be wrapping around and appearing at the bottom. Now you could bring your baseline down for this. It's not going to get rid of aliasing. Aliasing does not adjust the maximum velocity of our scale. It just moves the baseline. So you are going to move that baseline down, but you are still going to see this much, right? You're still going to see something coming across the bottom of that screen. You're still going to be cutting off something on the top of the screen because you're not set to view the true velocity that is higher than what you are set at currently. Okay, so that was a lot of just Doppler information that can be applied to any vessel that you are looking at. So let's talk mainly about abdominal Dopplers and the vessels associated with the liver, what they look like, how they should behave, and what you can expect to see if they are doing this protocol on an abdomen at clinical. So some indications as to why a patient would need these pictures done. We've talked about this previously, but any patient who has cirrhosis, whether it be acute or chronic, even some hepatitis patients will come in for Doppler exams as well. Anyone with questionable portal hypertension, we're going to talk about that a little bit further today. Portal vein thrombosis, we're going to get to that as well. Also a TIPS evaluation. Any patient who has had a partial or total liver transplant is going to be getting Dopplers done of those vessels to make sure that they aren't rejecting that organ. And any patient who has Budd-Chiari syndrome, as we've learned about, that is that obstruction of the hepatic veins draining into the IVC. So of course we want to be evaluating those veins with this type of protocol. So our protocol, regardless of the reason as to why we would be doing an abdomen with Doppler or a liver with Doppler, we are always going to be sampling, meaning we are always Dopplering the splenic vein, hepatic artery, main portal vein, left portal vein, right portal vein, and the left, middle, and right hepatic veins. Some places will have you do even more than that, where you will go in and sample the aorta and the IVC. Some places may have you do less than that, but this is kind of the meat and potatoes of doing a Doppler protocol. Typically, you will start with the splenic vein, and as we know, that's going to be prominently seen at the pancreas. We want to evaluate at the tail of the pancreas because that's where we know that it's coming right from the spleen, right? So you can go to the hilum of the spleen and document the splenic vein, but we do want to see it as it gets closer to that portal splenic confluence as well. So some places will have you obtain the splenic vein in different locations. Mainly, you are going to be Dopplering it at the tail of the pancreas. Now, at the tail of the pancreas, as we know, when we're putting color Doppler on that pancreas at that splenic vein, it's going to appear like it is traveling towards the transducer. So it's going to appear red or whatever color is indicated above the baseline of our color map. As it kind of hops up and over and then down to the head of the pancreas, it's going to appear like it's traveling away from the transducer. So that is going to be represented by blue or whatever color is below the baseline on our color map. Our splenic vein is going to have continuous flow, which we're going to talk about in a second. It's going to be low velocity, and we are going to see this flow represented typically above the baseline. Again, it depends on where we are sampling it and making sure that all of our other properties are properly set. Then we also have our hepatic artery. So this is the only artery that we are Dopplering. So this one is going to appear very pulsatile like most arteries do. So we have to make sure we are using angle correct for any artery in the body. That's where we make sure that our gate has that angulation on it. Typically, a normal, healthy hepatic artery is going to display hepatopedal flow, which means flow into the liver, hepato, liver, pedal, into. And then it's also going to be pulsatile, as we said. Arteries are typically going to be high velocity. So we're going to be getting a measurement, a peak systolic velocity measurement of about 100 centimeters per second. So when we're Dopplering that artery, we want to make sure that our scale is set pretty high. This is also going to appear above the baseline. This has a positive Doppler shift. We then have our main portal vein, so right next to our hepatic artery. Similar to the hepatic artery, but a little bit different. We know our main portal vein, yes, it's a vein, but it does arterial functions. It supplies an organ, right? Veins typically drain organs, but the main portal vein supplies an organ. So we are also going to make sure that we are angle correcting for that. It's still going to have hepatopedal flow, so flow into the liver. Unlike the hepatic artery, it's not going to be pulsatile, right? Because it's not an artery. It's going to have monophasic, kind of continuous, what we call respiratory phasicity flow. We're going to talk about those types of flow in a minute as well. And this is going to appear above the baseline. So again, positive Doppler shift. It is moving towards the transducer. Then we have our left portal, different from each other. The left portal vein, again, we're going to have that monophasic continuous flow. It's going to be above the baseline. We know it's going to divide our left lobe of the liver into medial and lateral branches, or kind of sections. So it's going to have medial and lateral branches that come off it. The left portal vein is very important in terms of liver pathology. So when we get to some of these topics, we are going to be talking about that left portal vein a little bit more. On ultrasound, it's going to appear as a red branch coming off of the main portal vein, so it's heading towards the transducer even more. Now our right portal vein, this is going to still be monophasic, continuous waveform. This is going to show flow below the baseline, so it's moving away from our transducer now. It's coming from that main portal vein and it's diving down to go and supply that right lobe. It's going to split into anterior and posterior branches, and it's actually going to appear as the blue branch coming off of the main portal vein. So it's showing that it's traveling away from the transducer as it dives down into that right lobe from the porta hepatis. As for our left, middle, and right hepatic veins, they all pretty much appear the same on Doppler analysis. They represent respiratory phasicity. So it's typically kind of like this unique variation of triphasic flow, and these are all going to be below the baseline. So veins are below the baseline. Arteries are typically going to be above the baseline. But when it comes to the liver, our veins kind of do things, right? So some of our veins are going to appear above the baseline, like we said, the main portal vein, and the splenic vein is also going to appear above the baseline, even though we know that veins should probably be below the baseline. So let's take a look at what this phasicity means, or this type of phasic flow. When we talk about phasicity of a waveform, that means how many phases does it go through? When we have an arterial pulsatile vessel, the arteries are undergoing that rapid contraction of the heart, right? So we have the lub-dub of the heart. And as those high velocity blood contractions come through a section of an artery, it's undergoing, it's kind of traveling in these three different phases. It's responding to those different kind of, I guess you could say, segments of the cardiac contraction. So you have what we call triphasic, biphasic, or monophasic flow. Is it going through 3 phases? Is it going through 2 phases? Or is it going through 1 phase and it's not really responding to anything else? Venous flow is typically going to be monophasic, or what we call continuous. It has this continuous flow that doesn't really change in velocity at all. Now, when you have triphasic, that waveform is going through 3 different phases. So it's going through a peak systolic and an early diastolic and then an end diastolic. So the arterial contraction is a little bit more complicated than the venous blood flow return. If we look at the examples on the left side, we have triphasic on top, biphasic in the middle, monophasic on the bottom. Now, as we said, monophasic is normal for veins. We don't really talk about tri, bi, or monophasic for veins. Mono is totally normal for them. If you see monophasic flow in an artery, that is severely abnormal, okay? So we always want to be seeing triphasic, and sometimes biphasic is okay for an artery, depending on the patient's clinical history and what they have going on. Anytime you see monophasic flow in an artery, there's pathology. So this is what the waveforms are going to look like on our spectral analysis. As we said, really the only thing that's going to represent like a strong triphasic flow is going to be that hepatic artery. Everything else is going to be more of a continuous flow. And this is where we get to the pictures on the right side. So our veins, as we know, as we've been scanning our IVCs, our veins respond to our breathing. So it's a different type of phasicity, right? We just said with the arterial system that we have triphasic, biphasic, monophasic. With the veins, we have more of this continuous flow, but then we also have respiratory phasicity. So some veins are going to respond to our breathing, some veins are not. Our splenic vein, not really going to respond to our respirations. So that's going to be a continuous flow. That velocity is really not going to change. That's that picture on the bottom right of our screen. When we have respiratory phasicity, this means that yes, we still have this continuous flow, but we're starting to see these kind of discrete variations in the velocity of that waveform. So we have below the baseline for both of these. So we have negative Doppler shifts. They are moving away from us. These are both veins on the right side. But this top picture, we see the velocity increases here and then starts to decrease a little here. And then it increases again here and starts to decrease here. This means that it's responding to us breathing. So our breathing is having an influence on this vessel, right? On the contraction and relaxation of that vein. Obviously, it's less dramatic than the arterial system, so we kind of treat it as its own type of phasicity, respiratory phasicity. So let's take a look at the actual appearances of the vessels in terms of our protocol. So we said we're typically starting with our splenic vein first. Here we have two examples. Our picture on the right side, it's just a nice kind of diagram showing our transducer coming in here. And as we see the splenic vein coming up, we see that it's traveling towards our transducer, so it's represented as our color flow above the baseline, our red, as it travels along the body of that pancreas and becomes into our portal splenic confluence. It's traveling away from our transducer, so it's represented by the color below the baseline, away from us. Now, as we Doppler that splenic vein in the tail, this is me actually scanning myself, which was a little bit challenging. As I'm Dopplering at that splenic vein of the tail of the pancreas, you can see that I'm getting this very continuous waveform. It's above the baseline because this portion of our splenic vein is traveling towards our transducer, so it's going to be presented above the baseline. Low velocity waveform coming in probably just over 10 centimeters per second. I did not measure it. I could have decreased my scale a little bit, maybe down to 30, but just retrospectively, that's something that you can be aware of as you are evaluating your own images and while you're practicing. Next, we have our main portal vein. So this is going to be a little bit different for everyone depending on how you get it. But if you look at the spectral analysis of both of these images, they are continuous, right? There's not much of a variation with them. This patient on the right side, there's a little bit of respiratory variation here. So that's still normal. And then this one's a lot more continuous. So this one, they could have had the patient hold their breath to get it. So we're not seeing any of that variation in the respiration or in the velocity of that waveform. As we know, our main portal vein is traveling towards our transducer, so it's being represented as a positive Doppler shift above our baseline. But if we look closely at our image, we can see that we're using two different angles to evaluate these main portal veins. The picture on the left side, we have a very steep vessel, right? The vessel almost looks like it's coming directly up the screen. So we have to match that angle. And if you look very closely, you can see the angle of our gate is very steep there. Picture on the right side, we're coming in at a little less steep of an angle in terms of our main portal vein position. So our gate angle is nice and parallel to that vessel, a little less steep than the image on the left side. Next, we are moving into our right and left portal veins. Our right portal vein, as we said, is going to dive down off of the main portal vein. So it's going to be represented by the color blue, or whatever color represents below the baseline in our color map. It's traveling away from us, so it's now a negative Doppler shift, and we're going to be seeing our flow below the baseline. So here we have our main portal vein coming into the liver. We have our right portal vein going down into the right lobe of the liver. And here we have our Doppler of that on the right side of our screen below the baseline, seeing some of that respiratory phasicity a little bit here, but still nice and continuous flow. Next, we have our left portal vein. So we have our main portal vein coming in here. We can see our right portal vein right there, that little blue branch coming off. And then we have this left portal vein right here. Now, our picture on the left side, a little bit zoomed in, a little bit better of an image, we see that filling in, but if we look really closely, it starts to really not fill in that much, kind of like right over here, right? And that's because this is all going to be that remnant of that left portal vein. Remember we talked about that, how that closes shortly after birth, or it can recanalize in presence of pathology. This is going to be very important when we are a patient with portal hypertension and cirrhosis. So our left portal vein, we're not going to be evaluating it all the way to the tip of that left lobe of the liver because it pretty much kind of just branches off and divides by this region here. And again, nice continuous waveform above the baseline because it's heading towards our transducer. Here we have our hepatic artery, so we're kind of going back to our porta hepatis. If we look too, this is like a really nice right portal vein coming off right here, kind of a grainy picture, but still a nice shot there. We are looking at the really tiny vessel sitting right above that main portal vein there. So we have our spectral analysis. We see that arterial flow. This probably is a biphasic waveform. Spectral analysis is not that great. Right there, just because this is a grainy picture. Looks like we're coming in. We have a scale set to about 80, so rather appropriate. We can maybe come down a little bit more to occupy more space in that spectral window. It's important for us to know that when we are doing a hepatic artery, you have to measure the peak systolic velocity. That is what they are doing here with their caliper, and they are getting a value here. I'm assuming 50 something centimeters per second. Not the easiest read. Picture on the right side a little bit more clear. We see that pulsatile vessel right on top of our hepatic artery. We see our scale is set to 40, and we are getting a triphasic waveform, and they are measuring here above the baseline, heading towards the transducer. Moving into our hepatics. So our hepatics, as we know, drain the liver. We have right, middle, and left. Our middle and left will drain together before entering the IVC. The right drains on its own. So here is how I like to obtain the left hepatic vein. You can obtain it in the view from the previous slide. So right here, that's typically going to be a subcostal transverse view, but it's a little bit hard to evaluate the left hepatic vein in this view. This picture right here, very rare to get that. This is more likely what you're going to get from that view. So I like to go sagittal left lobe, and we see this beautiful left hepatic vein draining right into that IVC, really close to our heart here. And as we put color on, we see it appearing blue below the baseline, negative Doppler shift. This is where we get more of our true respiratory phasicity. So these are pretty drastic variations in velocity. This is very normal for the hepatic veins. We want to see that below the baseline. There is a sort of rhythmic pattern to them as well, and that is because of their close proximity to the heart. As we know, they drain directly into that IVC. That IVC goes right into the heart. Look at our picture on the left side. Look how close our heart is located to those hepatic veins. They are going to pick up on those contractions of the heart, of the lub-dub of the heart, but it's still a negative Doppler shift, still below the baseline, still a venous waveform. So we're not seeing that true triphasic arterial waveform. And our middle and right hepatic veins are going to appear very similar to that. Again, we're getting this little flow reversal here. Anything that goes in the opposite direction of your waveform, whether it be an artery that goes below the baseline or a vein that goes above the baseline, that's going to be normal for the hepatics. Again, close proximity to the heart, so we're picking up some of that on our Doppler. But again, true respiratory phasicity, we're also responding to cardiac contractions. Okay, moving into some of the pathologies that we briefly touched upon. Portal hypertension. This is a big one and has become increasingly more common in our patients. This is when we have that increased pressure of the portal venous system because of some type of obstruction in the liver, right? So how is our venous system going to be responding to that increased pressure? The main thing that we are going to see is we are going to see an enlarged main portal vein diameter. So it's going to appear really dilated. If we look at this picture on the right side, you know that the main portal vein is usually not that big, right? So that is going to lead us to put calipers on it. And as you can see, we're getting a measurement of 13 millimeters. The slide should say anything greater than 13 millimeters. If it was anything greater than 13 centimeters, that's like the whole width of your liver. So that would be wild. But 13 millimeters, 1.3 centimeters. We are also going to see collateral. So sometimes we are going to get these additional pathways that our body creates to kind of bypass whatever the blockage is. We're going to see an enlarged spleen, potentially an enlarged liver if it is acute. And then over time, we could see an atrophic liver. We could see ascites as well. And then on Doppler, this is where we're really going to be evaluating, particularly that main portal vein. So we know that the main portal vein should have hepatopedal flow. When we have portal hypertension, we could see flow reversal or bidirectional flow. So we could see flow out of the liver. And that's because if the portal vein is trying to send in blood flow and the liver's saying, nah, nope, you're not getting through, well, where's it going to go? It's going to go backwards, right? It's going to be like, all right, well, I got to get out of here somehow, so I'm just going to go backwards. So we could see that flow trying to get in and then being rejected out. And that would be our bidirectional flow, or the hepatopedal and hepatofugal flow. Remember, hepatopedal into liver, hepatofugal out of liver. It's going to appear low velocity with a continuous waveform. We said it's going to appear bidirectional. We are also going to see very commonly a recanalized umbilical vein. So that left portal vein is going to open back up. That remnant of the umbilical vein, which is that distal portion of the left portal vein, is going to open up and blood flow is going to go right out of the liver through that vessel. We're also going to see lack of respiratory variation. So we're not going to see that normal kind of slight change in velocity of that waveform. Again, we want to be aware if we are having our patient hold their breath for the Doppler of the main portal vein, we need to document that because it's going to make it appear continuous. We want to see slight variations in that main portal vein waveform. And when they hold their breath, it makes it appear continuous. But if they're breathing normally and it still looks continuous, that's going to be a sign that there's some type of obstruction or increased pressure in the portal system. We're also going to see a decrease in velocity. Now remember, the main portal vein is already low in velocity, about 20 to 40 centimeters per second. So anything really less than 20 centimeters per second is going to be really low velocity, and that fluid is going to be traveling really slowly. And it also could have an increase in velocity if we have a recanalized umbilical vein. So if we have other pathways for that blood to travel through, that velocity could appear normal or could even appear higher because it has extra pathway to go through. So let's take a look at what that recanalized umbilical vein looks like. So on the left side, that is we would assume that our main portal vein is coming up here, and then it's branching into our left, and then whoa, right, going right out that liver. Very prominent. And as we put color on it, it's going to light up like an angry snake. We can actually follow that recanalized umbilical vein all the way down into the patient's intestines. And that's how it gets out. So pretty interesting to see when you're first learning, but unfortunate if you are the patient. So hepatopedal versus hepatofugal flow, we've already talked about this. Hepatopedal into the liver, hepatofugal out of the liver. Everything that we should be seeing at the porta hepatis should be hepatopedal flow, and the hepatic vein should show hepatofugal flow. Now, if we look at the picture, top left, this is our porta hepatis. Our portal vein appearing blue below the baseline, away from us. That means it is traveling out of the liver. That is hepatofugal flow. That is abnormal. Image on the top right, same thing. Below the baseline, abnormal. If we look at the picture bottom right, this is our normal picture, represented by red, which I would assume would be above the baseline of our color map, and our waveform is appearing above our baseline as well. Nice normal hepatopedal flow. And then our picture bottom left, this is bidirectional. So this is that hepatopedal and hepatofugal flow. So this is when the blood is trying to get into the liver here, and when it's getting kicked out. Trying to get into the liver, getting kicked out. So we're seeing that bidirectional flow or that flow reversal in those cases. And if you look really closely, the vessel mainly is appearing red, but you also have these areas appearing blue. So we're seeing the color representation of that flow rejection as well. So how do we treat portal hypertension? It doesn't sound like the best thing to have, right? The main thing that we are seeing and that we can evaluate for on ultrasound is what we call a TIPS procedure. This is a transjugular intrahepatic portosystemic shunt. The registry loves questions about the TIPS procedure. We will get into this more in our vascular class, but basically they go in through your jugular vein. They go down into your IVC and they put a kind of a shunt right between the hepatic veins and the portal vein. So if you look at the diagram on the right side, that's a pretty basic, good representation. Our flow is coming in here. It's getting blocked, right? For some reason, whatever reason is causing the hypertension, the resistance. So we put a shunt for the blood flow to go directly from the portal system right into the venous system out. So that's how we can relieve some of that pressure buildup in the liver. The most common placement of this shunt is going to be in the right portal vein, connecting it to the right hepatic or the right middle vein, the right hepatic or the middle hepatic vein. And of course, anytime a patient has this procedure done, we need to be doing a Doppler exam to make sure that that shunt is patent. And we will learn all about those values in our vascular class in the fall. Next, we have portal vein thrombosis. So this is when we have a blood clot in the portal vein, particularly the main portal vein. Symptoms of this, a lot of patients, if they have chronic thrombosis in that portal vein, they are going to be asymptomatic, and that is because their body has formed collaterals around that blockage to get blood flow to travel where it needs to go. But if you have acute portal vein thrombosis, so all of a sudden you have this big blood clot that's just jammed right up in your portal vein, you are not getting your blood supply into the liver, it can result in intestinal ischemia. So what this means is our portal vein, the supply comes from our intestines, right? So if we have a blockage in our main portal vein, it's going to result in tissue death of the intestines because the flow draining it is not accurate, is not appropriate. It's not going where it needs to go. This blockage is causing kind of like a pileup on the highway. So the intestine vessels start to occlude and the intestines result in tissue death because they're not getting proper drainage. Now, most cases of portal vein thrombosis, the patient's going to have splenomegaly, ascites, can result in a gastrointestinal bleed. And on ultrasound, we are going to be able to evaluate that blood clot. So it's going to be echogenic, again, depending on how old it is. It's going to be either partially or totally occluding that vessel. Occluding means that there is no blood flow getting through it. Partial occlusion means that there's some blood flow. So we are going to be doing an evaluation of that vessel with color and Doppler. And if we think about how this behaves to the liver, our portal vein is responsible for 80% of supply to the liver. Hepatic artery is responsible for 20. So that hepatic artery is going to be working double time to supply that liver. So we are going to see increased hepatic artery flow. And all of these are really great examples of what a thrombus can look like. This top image, I believe, is of the left portal vein. We have a clot there causing dilation of the rest of that vessel. We have a real big clot here. Oof. And then we have this monster clot extending the entire main portal vein, even going into the right and the left portal vein as well. And lastly, cirrhosis. We've talked about cirrhosis quite a bit. We know the difference between chronic and acute. We know how we get cirrhosis. On ultrasound, we can be doing an abdominal with Doppler exam, but we are more commonly sending patients for what we call elastography. And this is a different type of ultrasound application that we can use to actually test the density and the stiffness of the liver tissue. So it's a little bit more accurate than just doing Dopplers. Sometimes Dopplers don't really give us much more information. So we want to be testing that fibrosis of that liver tissue. We are going to see nodular contour, meaning that border of the liver is going to start to become a little bit lobulated. We're going to see coarse echo texture, so the liver itself is going to start to appear more heterogeneous. We know, depending on the age of the cirrhosis, we are going to see an enlarged caudate, and that can lead to IVC compression. And typically for cirrhosis, whether it be acute or chronic, we can see main portal vein flow reversal. We could see low main portal vein velocity. We could see increased pulsatility of the main portal vein, and we could see turbulent color pattern when we are just using color Doppler on that main portal vein. So the cirrhosis is mainly going to be affecting that main portal vein. And lots of information on this PowerPoint. You are going to be responsible for this in terms of a quiz or testing, but just remember that we are coming back to this in physics, and we are coming back to this in our vascular course as well. Please do not hesitate to ask me any questions on this. Also, you can look up some additional information about Doppler, chapter 19 of your Edelman book, if you need a little bit more clarification. I believe 19 and 20 as well. I'm not 100% sure. But 19 really gets into the principles of Doppler. For me, for now, this is all you have to know in this class, but be aware that for physics, we will be getting way more in depth with that in the weeks to come. So please feel free to reach out if you have any questions.